It's a startling figure. Dementia affects as many as 5.5 million Americans. Among people aged 85 or older, the occurrence of Alzheimer's disease, which is just one form of dementia, is as high as 30%. An estimated 50% of older adults report subjective memory complaints. Now, dementia can be difficult to diagnose. Most people aren't diagnosed until later stages of the disease. In an effort now to help diagnose patients, there are a variety of tools that clinicians can use to evaluate cognition, one of which is called the Montreal Cognitive Assessment, or MoCA. Hello, everyone. I'm Terry Wood, and thank you for joining us for this program. In the program today, we'll talk to several experts. We'll also discuss why and how to administer the MoCA in a clinical setting. And we'll delve into such topics as reasons for measuring cognition in primary care, features of the Montreal Cognitive Assessment, or MoCA, as we will call it throughout the program now, administration and scoring the MoCA, and the use of the results from the MoCA for patient care. And along with discussing the benefits and the specifics of the test, we'll have some video dramatizations that show the test being administered to both an impaired patient and one with normal cognition. But first, let's meet our guest today. Dustin Hammers is a board-certified clinical neuropsychologist. He practices at the Center for Alzheimer's Care, Imaging, and Research at the University of Utah, and he also conducts telehealth services for the VA Medical Center in Salt Lake City. Brett Hicken is a clinical geropsychologist. He specializes in assessment and treatment of cognitive problems in older veterans. He practices at the VA Medical Center in Salt Lake City. And Natalie Manley is a geriatrician with special interest in caregiving and dementia. She practices at the University of Utah Hospital and at the VA Medical Center in Salt Lake City. So thank you all for joining us today. Let's begin with you, Dustin. Would you tell us briefly about MoCA?
Certainly, Terry. The MoCA is a cognitive screening tool that looks at a number of different areas of thinking, each of which we're going to go into in more detail in a moment. But briefly, it does look at visual skills, naming abilities, memory problems, attention abilities, language difficulties, delayed recall of memory, abstraction, and orientation skills. And the MoCA test itself is fairly easy to administer and can be done so by a number of different professionals. One great thing about the MoCA is that it is available and free to use online at mocatest.org, where you can find different forms or versions of the test, scoring procedures, and administration protocols.
And Natalie, as a physician, why is it important to assess cognition in primary care?
Well, that's a really good question, and there's several different reasons to assess cognition in primary care. So, first of all, the decreased cognition impacts the way that we as physicians or clinicians should be caring for our patients and also communicating with our patients. For example, if somebody has dementia, it's best if we write down our recommendations for them so that they can remember what we said when they go home. Also, medication side effects are important, and the medications that we prescribe for them, we should be careful about what we're doing. For example, sedatives and anticholinergics are going to be a lot more impactful on them and potentially cause delirium for them, and so we need to be careful of that. Diagnosing a person with dementia early on is helpful because then we can help them to start preparing for safety issues. So helping them to prepare for problems with driving, guns in the home, or making the home more safe in general. Also, identifying patients needing more extensive evaluation is important in regards to cognition. So some of our patients will present to us with cognitive issues, and we can then look for things that can be potentially altered to help with their cognition. For example, looking for hypothyroidism or depression that, if we fix those things, could potentially help. Advanced planning is important because then if we diagnose the dementia early, the person who has the dementia can be a greater participant in deciding what they want their future to look like. And then we can also track changes over time so that the family members and the patient is able to know what lies ahead for them in the future.
Now, Brett, going further with the evaluation, why would you track these changes over a period of time?
That's actually a really good question, and it comes down to the definition of dementia. It's an acquired condition that is a decline in cognition or cognitive abilities over time, at least 2 cognitive abilities, and those have to be severe enough to actually affect the patient's ability to function. So inherent in that definition is this decline in cognition over time. And so if a patient actually isn't experiencing decline or hasn't declined, then technically they don't have dementia. So if we look at the different types of dementia, the major types of dementia, we've talked about Alzheimer's disease already, but there are other forms like vascular dementia, frontotemporal dementia, dementia with Lewy bodies, and Parkinson's disease with dementia. All of those different types of dementia have different symptoms, different etiologies, but one common symptom that they all share is this decline in cognitive abilities over the course of the disease. So the MoCA can be a really valuable test in not only detecting decline, but then measuring that change over time to help establish a course of the disease being dementia.
Natalie, as we mentioned earlier, dementia may not be recognized in its early stages, so when should a provider consider testing a patient?
So the times that I think about testing a patient is when a person or their family members come to me and say, "Gee, doc, I'm having problems with my memory." So that would be an obvious time to check their memory. Also, if a person comes to me with a new onset late life depression, that also would trigger me to think about looking for problems with their cognition, because cognition and depression can go hand in hand. If I notice problems with the person having difficulties with attention and paying attention to certain tasks, or also having difficulty with managing their daily life activities, for example, managing their medications appropriately, managing their bills, doing well at their job, those would all be things that would make me think that I should be checking for problems with their memory.
So it seems that the earlier we can screen, the better the care is going to be in the long run. Dustin, when it comes to this early screening here, what, in your opinion, makes for an effective test?
There are a few different things that can factor in when considering ideal screening tests. One is that it's important for them to be relatively brief. Providers are quite busy. Patients have a lot going on. There's a lot that goes on in the doctor's appointment in general. So something that is quite brief and at the same time can be well tolerated by patients is really helpful. Secondly, we want to make sure that the materials themselves are easy to administer and also to score. We don't want to introduce a lot of mistakes or potential for mistakes by having very confusing administration needs. So something that is straightforward is very helpful. Tests should also be quite sensitive, which means that if an individual has difficulties with thinking, the test should be able to identify that. On the flip side of that, if an individual does not have difficulties, the test should be able to pick up that they're doing well as well. And that's called specificity, which is an important component as well of any kind of screening test. When we're thinking about demographic variables that could impact testing, there are factors such as age, education, race, gender. All of these things we would like to not have a major role with our screening measure. So a task that's free of those biases is very important. And then finally, would like our task to look at a number of different areas, because in day-to-day life, there are a number of areas of thinking that we need to use.
Now, this brings us to the MoCA, or the Montreal Cognitive Assessment. Brett, why would you use the MoCA over other screening tests?
Well, thinking about what Dustin has just told us about a good screening test, the MoCA actually meets all of those criteria. It's a simple test. It assesses multiple cognitive abilities. And it also is very sensitive and specific. So it identifies patients who have impairment, even mild forms of impairment, which is really important. And then it also is a pretty good test at not identifying as impaired those patients who in fact are doing okay. There are also a variety of versions of the MoCA which can be really helpful for example, patients who speak a different language. The MoCA is available in multiple languages. There's also 3 English versions of the MoCA. So you can administer one version and then administer another version later on and not worry that the patient's learning how to take the test from one test to the next. And then there's also a visually impaired version of the MoCA for patients who may have a difficult time seeing some of the items that are on the test. There's also, because of the range on the MoCA, there's a range of performance that a patient can score in, and so that's nice because it allows us to see variation in their scores and track that change over time. One of the things about the MoCA that I think is really nice is that because it's simple, it's brief, it's easy to use, it can be administered by a variety of professionals. It doesn't have to be a doctor or a psychologist who's doing this test. It can be a variety of clinical staff like a nurse or a social worker who are using this with the patient. And then it can also be administered remotely through video conference or some sort of telehealth modality. And then finally, as Dustin already mentioned, the test is free. And some tests aren't, and so we can download that from the website at mocatest.org.
That does seem to cover a wide array of topics in diagnosing dementia. Natalie, what does the research tell us about MoCA?
So I've actually been impressed by the research behind the MoCA. The data supporting it has shown that there's stability over time, meaning that if a person takes the test today and then takes it again a month from now, the scores will be approximately the same, less than a point over a month interval. And this goes together with good test-retest reliability. It has a correlation coefficient of 0.9, which compared to other cognitive tests is actually really good. In regards to sensitivity and specificity, it has 90% sensitivity for detecting mild cognitive impairment and 100% sensitivity for detecting Alzheimer's dementia. In regards to specificity, it has 87% specificity for identifying cognitive impairment as compared to normal controls. So if a person scores 26 or greater, you can be fairly sure that the person, if they're tested with a more thorough neuropsychological assessment, is not going to have cognitive difficulties.
Those are some pretty good results, especially the 100% on Alzheimer's. We're going to watch some dramatizations in a few minutes, but before we do, Brett, tell us what considerations providers should be thinking about when they administer the MoCA.
Well, we want to be thinking about time as an issue first, and again, that's another reason why the MoCA is really helpful. It's a pretty brief test, about 10 minutes to administer. That'll vary, obviously, depending on the patient that we're seeing, but it can be done fairly quickly. We want to try and make the patient feel comfortable, and so we want to make the setting that we're doing the test in as quiet and distraction-free as possible. So if I were doing this test in my office, for example, I would put the phone on ringer on mute. I might put a sign on the door or something just to let people know that we have testing in progress so we don't have people knocking on the door. Again, we're trying to make the patient feel comfortable and help them to do as well on the test as possible. We want to make sure that there's some sort of hard writing surface for the patient. A table is great if that's available, or even a clipboard or something else hard that they can write on. And then we'll need a couple of items to help us complete the test. Of course, a pen or something to write with, a stopwatch or timer, or anything that has a second hand or allows us to track the seconds, because there's a timed portion of the test. And then, of course, a copy of the MoCA test itself.
That would help, wouldn't it? Now, during this portion of our broadcast, we're going to be going through the test with some recorded dramatizations. These are dramatizations with two patients. One we call Mr. Johnson, the other is Mr. Green. Now, of the two, Mr. Johnson has more cognitive difficulties. So, Dustin, would you introduce the first part of the MoCA?
Sure, Terry. What we're going to be seeing first is a section of the MoCA that is looking at visual skills and executive abilities. And what that really means is your ability to perceive visual information that is around us in the world, and our ability to plan and make decisions based on that information. And so there are three components of this first part of the test. The first is a sequencing component, where we're going to ask the patient to sequence a series of numbers and letters in increasing order. Next, we're going to have them copy a cube in a three-dimensional fashion. And then finally, we're going to have them draw a clock set to a specified time.
All right, let's watch that first video clip.
I would like you to draw a line from a number to a letter in increasing order. 1 to A to 2, and so on until you get to the end.
I'm sorry, I don't follow that. Can you repeat that?
Yes, you will draw a line from number to letter to number and continue until you get to the end.
Okay. From A, I mean 1. From 1 to A to B to C to D to E and 2, 3, 4, 5, E.
Okay, thank you. Do you see this drawing here? I would like you to copy it right below here as accurately as you can.
I don't understand what I'm doing here. Can I do this again?
Sure, go ahead.
Okay. I don't get this. I'm sorry.
That's all right, Mr. Johnson. Not everyone gets everything exactly right. All right, I would like you to do one more drawing. Right here, I would like you to draw a clock. Put in all the numbers and then set the time to 10 past 11.
Okay. What time did you say it was?
10 past 11.
It's going to take me 10 or 11 minutes to finish this thing.
Take your time.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11.
Thank you.
It's very interesting. Dustin, as you watch this video, what did you see?
Well, Terry, there are a number of things that I think is important to point out, both as far as Mr. Johnson's performance, as well as scoring criteria in general for the three different portions that Mr. Johnson just completed. The first is with the sequencing task, where he needed to sequence numbers and letters in increasing order. And as you could tell, Mr. Johnson had some difficulty with this. And so, because he did have trouble going in proper order, he did not get full credit for this, as you could tell by the provider's X in the brackets there. The examiners are shown scoring the visual spatial tasks right away, but in a real situation, the clinician should score it at the end of the naming subtest. When we're thinking about his performance copying the cube, there are a few things to keep in mind. One, he had a little difficulty in the beginning and asked if he could get a second attempt, and that is perfectly okay to have him go a second time. when we're looking at scoring his performance, there's a few things to consider. First, is the cube that he drew three-dimensional in nature? Did he draw all the lines he was supposed to and not add anything else? Or did he add other lines? And then are the lines that he drew relatively parallel to each other and of relatively similar length, or was there some distortion? And so when we consider Mr. Johnson's performance here, we could see that he did struggle to create a three-dimensional shape. He also, there are some lines that are missing, and they're definitely out of parallel. So I would say that he would not receive credit for this performance either. Because there are a number of factors to consider for scoring the cube in this portion, I think it's helpful to consider other examples. And so on the screen, you're going to be able to see examples A and B, where I would consider these are perfectly acceptable, appropriate performances. I would give full credit for both of these. In letter A, there's a slight distortion, let's say. The cube itself isn't exactly parallel, but we don't expect our patients to be art majors or perfect artists, and so it's perfectly okay that there's a little bit of inaccuracy. But then when we consider letter C, for example, I wouldn't give credit for this because there are a couple lines that are missing in the performance. And then example D, I think the lines themselves are just a little too out of parallel with everything else. So I wouldn't give credit for this either. The other component that Mr. Johnson went through right now was drawing a clock. And there are a few factors that we need to consider there as well. Number one is looking at the outer contour of that clock. Is it completed in a circle or oval shape? Secondly, we're looking at the numbers. Are the numbers in the proper orientation and where we'd expect them to be? And then number three, are the hands drawn to the appropriate time? And is the hour hand shorter than the minute hand, like we'd expect on a traditional clock? And we can see in this circumstance that Mr. Johnson was able to draw an appropriate contour. The numbers, he did have some distortion with the numbers, so I wouldn't feel that I could give him credit for that. And the hands were not drawn to the appropriate time point. And one last thing to mention is occasionally you may get patients who draw the numbers on the outside of the contour as compared to the inside. And that would be an acceptable response for that as well. When we consider other possible examples beyond what Mr. Johnson just provided in terms of clock drawing, in this setting, letters A and B I think would be perfectly acceptable full responses, whereas letters C through F each have some factor to them that would keep from us giving a full credit response for that.
Now, I've got to admit, I've never been able to free draw a perfect circle myself, but I can see where someone with cognitive problems could have trouble with this test. Now let's watch Mr. Green as he completes the next portion of the test.
Now, can you tell me what animal this is?
That's a lion. I feel like I'm back in kindergarten.
And this one?
That's a rhinoceros.
Here?
Camel.
Okay. Thank you, Mr. Green.
Well, Natalie, as you watch this video, what do you see there?
So you can see in this video that Mr. Green actually got all of these correct, but this isn't as easy of a task for everybody. So one of the common mistakes that we'll see is the rhinoceros, and it will be mistaken for a hippopotamus, and that would not be correct. It is okay for them to say rhino or rhinoceros. Another possible exception would be to call the camel a dromedary, and that would be okay.
Dromedary. People still use that word.
Every once in a while, you'll hear somebody mention that word.
And you get an extra
they get
point.
Yeah, not an extra point, just a point.
Okay. In our next clip, Mr. Johnson is completing a memory task.
Next, I'm going to give you a test of your memory. I will read a list of words that you will need to remember now and later on. Listen carefully. I want you to repeat them back to me as soon as I'm through. It doesn't matter in what order you say them.
I suppose I can do that.
Face, velvet, church, daisy, red.
I didn't quite get. Can you repeat those?
Actually, tell me what you remember, and then I will read it again to you in just a minute.
Oh, okay. Face, daisy, red.
Any others?
No, that's all I got. Sorry.
Okay, now I'm going to read the list of words again, and I want you to repeat back to me the words that you remember, including the ones that you mentioned before. Face, velvet, church, daisy, red.
Face. Velvet. Church. Daisy. Red.
Thank you. Now, you will need to remember these words again at the end of the test.
You know, we were all just agreeing our actors there are very convincing in these roles. Brett, why don't you tell us this time what you saw in that dramatization?
Okay, so obviously this is a memory test, and what we're going to be doing or seeing on the rest of the clips here is later on in the test, the patient's going to have an opportunity to say as many words as he can remember. So a couple of things that I noticed in that clip that I think are important to point out here. You notice that she did 2 different trials of the same list, and the first time the patient didn't remember very many words, and so after that second trial, he was able to remember all of them, and so it's really important that we do that second trial. Even if the patient gets all the words right, we want to make sure we do the same list again and give them a chance to practice it. We're trying to force them to rehearse to make sure that they're learning those words as best as possible. Another thing that happened during that is when she read that first word list, he said, "Oh, I didn't hear that. Can you repeat that for me?" And she told him, "No, I can't do that." And that's important to do. We don't want to read the same list twice before they tell us those words, because that invalidates that test. And then she told him to remember those words later on, again reminding him this is a memory test, so that he knows and may be trying to remember those words for later.
So it's very important that the test is administered in the correct way, too.
Yes, definitely.
Dustin, what comes next with MoCA?
Next is a series of tests looking at attention and concentration skills. And so what this is really trying to get at for the patient is their ability to perceive and process information that's coming at them, and their focus skills and their ability to not remain distracted but be able to manipulate information in their head. And so we're going to have them go through a series of tasks where they're going to repeat information back to us. They're going to follow along a series of letters that are read off to them. And then they're going to need to do some mental arithmetic, mental manipulation in response to some stimuli that we give them.
Okay. Sounds interesting. Let's watch it.
Okay, for this next test, I'm going to say a series of numbers, and when I'm through, I want you to repeat them back to me in the exact same order. Okay?
Okay.
Ready?
Yeah.
2, 1, 8, 5, 4.
2, 1, 8, 5, 4. It's like trying to remember the password to a computer.
Okay, I'm going to say a new series of numbers, and I want you to repeat them back to me, but this time in reverse or backwards, okay?
Okay.
7, 4, 2.
Okay. 2, 7, 4.
Okay, now I'm going to say a series of letters, and every time I say the letter A, I want you to tap your hand like this. Okay?
I think I can do that for you.
All right. Good. Now, if I say a different letter, do not tap your hand. Okay, ready?
Sure.
F, B, A, C, M, N, A, J, K, L, B, A, F, A, K, D, E, A, J, A, M, O, F, A, B. All right. Okay, now I'm going to ask you to count backwards by subtracting 7 from 100. Okay, and then I want you to continue to subtract 7 from your answer until I tell you to stop.
Now, what are we doing again?
Well, we're just trying to see how well you count backwards by 7. So start by subtracting 7 from 100, and then keep subtracting 7 from your answer until I tell you to stop, okay?
Okay, 100 minus 7, 93, 86, minus 7, 78. How far do you want me to go?
Can you give me a couple more?
Okay, well, 78 minus 7 would be 71, 64, and...
Okay, stop there.
Now, our Mr. Green did well, but he didn't get everything right. What did you see there, Dustin?
There was a lot going on in this clip right here for Mr. Green, some of which he did get correct and other things he had a little more difficulty with. Some things to point out was that he was able to get the number of digits repeated back to the examiner in the proper order when he was repeating it forwards, but he had some trouble repeating it backwards. So he didn't do that quite right, so he got 1 out of 2 points for that. And when the provider read off the list of numbers to him, it was read off at a proper pace, 1 number per second. The same cadence was provided the whole way through. There wasn't an inflection in voice at certain times, and in which would give Mr. Green a little bit of prompting. Similarly, when the tapping task was gone through, that list of letters was provided at the same pace the whole way through. One thing that sometimes providers make a little bit of an error on is when they say the letter A and are expecting a tap in response, they may look up a little bit, which can give the patient kind of an unintentional cue and a little bit of help with that. So it's important to make sure that you don't provide any additional assistance in that fashion, even though it's unintentional. And so for the last portion of this clip, we see that Mr. Green did pretty well with his mental arithmetic or mental subtraction. He was able to subtract 7 from 100 accurately and also subtract 7 from 93 accurately. He did make a mistake when subtracting from 86, but he corrected after that and got the last 2 calculations correct. And so what we want to make sure is that we are penalizing him for his mistakes, but not penalizing him multiple times. So we would only count 1 error here as compared to 3.
Oh, so he gets credit for managing the 7 subtraction on down the line.
Yes.
That's interesting. Yeah. Natalie, what will we see next?
So the next part of the test looks at language and a person's ability to communicate with other people. So the first way we test that is by looking at their ability to repeat a sentence. And then the next part is their ability to generate words. And in that way, then we can get an idea about how their ability to communicate is changing.
Okay, let's take a look at that clip.
Now I'm going to read you a sentence, and I want you to repeat it back to me exactly as you hear it. I only know that John is the one to help today.
I only know that John is the one to help today.
Now I will read you another sentence, and I want you to do the same. Just repeat it back to me. The cat always hid under the couch when dogs were in the room.
Can you repeat that?
I'm sorry, I can't.
The cat hid under the couch when dogs are in the room.
Okay, very good. Now I'm going to ask you to say as many words as you can think of that begin with a particular letter in the alphabet. You can say any kind of words except proper nouns like Bob or Boston, numbers, or words that begin the same but end differently like run and running. Are you ready?
As ready as I'll ever be.
Now tell me as many words as you can think of that begin with the letter F. Go.
Friend. Fine. Finger. Philly. Frill. 4. The number 4. Fickle.
Can you think of any other words that begin with F?
Find. Friend.
And stop. Now you said Philly. What did you mean by that?
Oh, the horse. My pop owned a horse farm when I was a boy.
I just wanted to make sure you meant the horse and not the city.
Oh, that's a P.
Very good.
Now, doesn't he get extra credit for knowing how Philadelphia is spelled in the short version? Natalie, why don't you elaborate on this clip?
So one of the things that I would point out in regards to the list making, he made several mistakes that are fairly common. So first of all, he used the number 4, and that is not okay. So he shouldn't get a point for that. Also, he repeated the word friend, and he'll get credit for the first time he said friend, but not for the second time that he used friend. And lastly, I would say in regards to the examiner that she did a good job by asking him to clarify what he meant by Philly to give him a chance to get credit for that. So he was able to say it was a horse and not Philadelphia, which maybe he feels he should get some extra credit for. So those are the main things I would point out in regards to the language section with the listing. In regards to the sentence section, he got the first sentence correct, but not the second sentence. And the reason he didn't get the second sentence correct is he omitted a word, which was always, and then he replaced a word, were, with are. So he said the cat hid under the couch when dogs are in the room, and he should have said were.
I was thinking R was correct myself there. It seems like she kind of helped him out, though, by reminding him of the task. Is that okay?
Yeah, and that's a really good question, and I had that same question myself when I was learning how to do the MoCA. And so in this situation, it's okay because the task is him being able to generate words, not his ability to remember what the task is. So it's okay for her to remind him about what task is being asked.
And anything else you take away from this clip?
So the only other couple things that I would mention is notice that there was a couple times that she looked at the clock, and that's just a reminder, make sure you always have something with the second hand available so that you can keep track of the time. And then additionally, in this situation, he asked for her to repeat the sentence, and she appropriately told him, "I'm sorry, I can't. Can you do your best to remember it?" And she did the right thing. One thing that I would point out, for him, he does have good hearing, but other patients don't. So just a reminder to be very clear and succinct and to speak at the appropriate volume when you're talking to patients who do have problems with their hearing.
And that the provider should know of their hearing or eyesight abilities or disabilities. In
Exactly.
Dustin, why don't you take us through the next portion of the test?
Now we're going to be asking the patient to apply some logic and look at their reasoning. And so this next section is a section on abstraction. We're going to have an individual go through and find similarities between different objects.
Okay, let's take a look at that clip.
Now tell me, how is a banana and an orange alike?
Oh, you can eat them.
That's true. How else are they alike?
Oh, that's a good question. I can't tell you.
They're both fruit.
Well, yeah, that's true.
Now tell me how a train and a bicycle are alike.
They're both wheels you can travel.
And now tell me how a watch and a ruler are alike.
They both measure things and whatnot.
Very good, thank you.
I liked his fruit answer. You can eat them both. What did you take away from this, Dustin?
You're right, Terry, that he was correct that you can eat an orange and a banana. But what we were looking for there is a higher level concept than just eating, but rather they're both fruit. And so in that circumstance, the provider was okay with providing the correction because that was the practice sample right there. But then in the other items that they went through, she wouldn't have provided a correction if necessary. In this case, he did a self-correction for how is a train and a bicycle alike. He started to say they have wheels, which I wouldn't have given credit for, but he then corrected himself and made a reference to transportation, which is good. And so we really, for this task, even though they may, the individuals may be providing some correct answers, for example, they have wheels, or they both are associated with numbers for each question, we're really looking at more a higher level answer, like transportation and units of measurement.
Kind of funny going through it. I wonder if I could pass the test myself on those levels. Brett, why don't you take us into the next section?
Sure. At the beginning of the test, we read some words and had the patient remember them. So now this is the delayed recall portion of the test where we're going to see how many words he's actually able to remember.
Okay, let's watch that video clip.
Good. We're nearly finished now, Mr. Green. Earlier, I read you a series of words and asked you to remember them. Tell me as many of those words as you can remember now.
Face, velvet, church, red.
Can you remember any more?
I don't think so.
Okay.
That's interesting too. Brett, what did you see in that one?
Well, the patient did pretty well. 4 out of 5 questions correctly. One of the things I do want to point out on that test, though, is you may not have been able to see from the video really well, but there's an optional portion of that test that was not administered. And the purpose of that section of the test is to give the clinician an opportunity to see if providing any cues will help a patient remember some of those words. So if he hadn't remembered any words, or maybe just remembered 1 or 2, the test administrator might provide some hints. So first he might provide a category cue. So for face, he would say it's a part of the body, and that'd give the patient a chance to remember that word. If he didn't remember the word, then he would provide a multiple choice option. So is it an arm, hand, or face? And then the patient would be able to choose from one of those options. So again, it provides us a little bit more information about what the patient can and can't do with regards to their memory.
And Natalie, I noticed you nodding over there. Is there something you wanted to add?
I find the optional section helpful in the clinic with my patients, because if they're having difficulty with the initial pulling the word from their mind, but then they get it when they're cued, that helps me to remind them that they do have strengths that they can use in their daily life, so that their family members can help to cue them to remember things as well.
Now we're coming to the last section of the test, and this one seems to me pretty straightforward. Is that correct, Natalie?
It is pretty straightforward. So this is the orientation section, and most of us in our practice test orientation on our patients on a fairly regular basis anyways. So in regards to the MoCA itself, the reason it's important for us to be testing orientation is to know if our patient has an understanding of time and place and is aware of their surroundings. So the person needs to be very clear and accurate about the date and being exact about that. And they also need to be able to say exactly where they are. So if they're in a clinic, they need to be able to say which clinic they're in, and not just that I'm at the doctor's office.
So this test really does seem to assess many areas of thinking. Brett, what else can you tell us about using MoCA in clinical practice?
Well, at the beginning of this presentation, we talked about helping the patient be comfortable, and that actually is really important part of administering this test. It needs to be an interactive, collaborative process. This isn't like a blood test where the patient is just a passive participant. They're an integral part of the success of this test, and so they're playing an active role, and we want to, as a test administrator, have a warm and encouraging demeanor. We want to help them to feel comfortable. We want to provide words of encouragement periodically during the test. If they do something maybe not as well, we want to encourage them to continue to keep trying. We want to, one of the things I like to do with patients is to help normalize the test for them. Sometimes this can be a little bit threatening experience, and so I try to help them feel comfortable by saying something like, I know you're having problems with your memory. We'd like to do this test that measures memory in other areas of thinking. This is something we would do with all of our patients, or many of our patients. And doing something like that often can really help the patient relax and feel a little bit more comfortable, especially if there are family or friends in the room with them. Another important aspect of doing the MoCA or any cognitive test really is to have a standardized administration. There are instructions, as Dustin mentioned, that can be downloaded from the website. And it's important as we're doing the test that we're following those instructions and making sure that we do the test the same with the patient every time we do that test with the patient, and across patients as well. And that ensures that the results that we get are as valid as possible. We're trying to establish an accurate baseline with these patients, and so doing it in the correct way ensures that that baseline is as accurate as possible. Another important part of standardization and helping the patient be comfortable is to establish some ground rules. And so, of course, I always tell the patient to do their best, and I always explain what we're doing before we just dive right in and get started. If there are family members present, it's really important to give the family some instructions as well. So I like to have the family sit behind the patient. Sometimes they like to help, or sometimes they'll leave an answer for the patient. And so we want them to be kind of away from the patient's line of sight so they're not nodding or giving some sort of cues. And then I always tell them that they need to be quiet while the test is being administered so that they don't provide any kind of assistance to it.
It's not a game show, no groans or applause or anything like that. As we watched our dramatizations there, we could see the providers were scoring the participant. Could you go into that a little bit more, Dustin?
Certainly. Something that I actually like to do is for each subtest as I'm going down the page is to score each of those up as I'm going, which allows me at the end of the task to simply add up or sum up the scores down the right-hand side of the page to get a total score. And there is also space at the very bottom of the page to add a corrective point for education, if appropriate. And what that means is that if an individual has 12 years of education or less, we're actually going to give them an additional point for the task to correct for any education component. So if someone has a college degree or has had college experience, we wouldn't give them that additional point, but otherwise we would. And so the total score for the MoCA is out of 30 points. And when individuals score less than 26, that is typically when we start considering that there may be some cognitive difficulty going on.
So you have the score, Natalie. What does it help you determine?
So one of the things to remember before you start interpreting the score is that it's not just one score, but it's a conglomeration of scores having to do with multiple cognitive domains. So that's the first thing to remember, is each one of those little scores means something and is important. Once you have this final score, a normal score is reassuring, and it gives me a baseline, or gives the clinician a baseline for where the person is at today, so that if problems come up in the future, they can retake the MoCA and we can compare the two together. If the person has a low score, it means just that. Their score is low, but it doesn't tell us why. And so we know then that we need to do more evaluation to help figure out, is there a cause behind their cognitive decline? It doesn't tell us that a person has dementia, so it can help guide us in that direction, but we need other information before we say that somebody has dementia.
The further evaluation's interesting. Let's say a patient does have a low score. Brett, how do you follow up with a patient with a low score? What do you do?
Well, there are a lot of factors that we might consider. Some of the sort of patient factors that we might look at are some things we've actually talked about already today, things like vision and hearing. Obviously, if a patient can't see well, they're going to have a hard time doing some of those visual spatial items on the test. If they have hearing problems, they'll have a hard time with most of the test because the instructions are spoken. And so we need to be aware of those things. Often before I do the test, I'll ask if they need glasses or need a hearing aid. And if I know they have problems with either of those two areas, then I'm taking that into account as I'm interpreting the test results. Another important factor to consider is motor function. If they have a tremor, say they have Parkinson's disease, for example, they're going to have a hard time doing the written portions of that test. And so again, that's something we need to be thinking about as we're interpreting what that means if they don't do that task correctly. Fatigue is another really important factor to consider. Some patients, as the day goes on, may become tired, and so their performance would be better in the morning. I know if I were to do the test after lunch, for example, I'd probably have a lot harder time doing it well than if I were to do it in the morning when I was fresh. We've talked about the education correction, and the patient's education, their literacy level is very important. Patients with less education are going to potentially have a harder time on the test, and so we need to factor that in as we're thinking about what a low score actually means. It may reflect simply low education and not actually cognitive decline. And then we've talked about motivation and rapport, and that this is very important. Patients who are not interested, who don't want to do the test, are going to have a harder time potentially doing the test well. And so again, we want to be encouraging and helping them feel comfortable to do that test, and then be aware of their motivation level as we're doing the test and incorporating that into our interpretation. And then finally, there's a language issue. We know that there are different versions of the MoCA for different languages. If English is their second language and we've used an English version of the MoCA, we have to be aware that may affect how they perform on that test.
Quite a few factors there that can affect the test. So Dustin, let's say that these outside factors have been eliminated. What does that mean for the low score then? Where do you go?
Well, if we have been able to rule out any likely extraneous or confounding factors, as Brett alluded to, then we need to start considering that this individual may actually be having some difficulties with their cognition. And this could be factored in and play out in a number of different ways. The most obvious possibility, and the reason why a lot of patients end up coming in to see a doctor, is because they're concerned about dementia. Specifically, they're concerned about Alzheimer's disease. And again, as Natalie mentioned, while the MoCA itself isn't used solely to diagnose dementia, it can give us some information that can help with a more comprehensive evaluation. There are a number of other reasons why people could be experiencing actual cognitive difficulties as well. Number one is mental health problems. So things associated with depression or anxiety or just daily stress. This can greatly impact the way we process information, and it can impact our memory and attention skills. There are a lot of medical conditions that are either long-term issues or more acute problems that can lead to difficulty as well. One example is for an individual who experiences a lot of urinary tract infections. It's very common for someone who has a UTI to develop what is called delirium, where they have a difficult time focusing and being able to comprehend and stay on task. And so what we tend to see is that there may be, for a period of time after a UTI, their thinking skills may not be very good, but if given enough time, that will resolve. Other conditions such as diabetes mellitus, type 2 diabetes, is one where if glucose levels are improperly controlled, if they're high sometimes and low other times, that's really going to impact people's thinking skills when the numbers aren't within where we'd hope for them to be. And then a couple other factors to consider are if someone has experienced a brain injury, there's a possibility of having cognitive difficulties from that, or if they've had a developmental difficulty in childhood that could still be playing out in adulthood with cognitive problems. And so the take home for the number of explanations possible is we want to really be looking at what are reversible conditions that with a little tweak here or there, we're able to improve the condition, which can then improve the thinking skills.
Well, you see how this would be very helpful information for the provider, too. Natalie, what else do you do when you see a patient with cognitive issues?
Great question. Everything that Dustin and Brett have already talked about are the things that I'm thinking about as I'm evaluating a patient who comes to me and says that they're having problems with their memory. So first of all, I need to take a really good history about what their disease course has been like, the time course, and also to be involving their family members or their friends who can give me some correlative history. So I need to know about their function and how well they're doing at home with their ADLs and their IADLs and their driving, etc. I also need to do a thorough physical examination, which includes a thorough neurologic examination, because there are several neurologic diseases, as Brett previously alluded to, that can also impact cognition. So I need to have an idea about that. Medications are really important to have a good idea exactly what medications a person is taking, because they might be taking over-the-counter medications that can affect their cognition. And then labs, although there's not a specific set of labs that is required for dementia, it is helpful to have a blood count, a chemistry panel, thyroid test, vitamin B12 levels, and if there's something that you see on their neurologic exam that's abnormal, it might make you think that maybe we should do some imaging as well. Depression is really important to look for, because depression can lead to problems with cognition. And if I've finally gotten all of this information and put it together, but I'm still really struggling to figure out exactly what is the cause of their memory problems, then I would consider sending them to a comprehensive neuropsychologic evaluation where they can give me more in-depth idea about what the person's deficits are. And then also, if there's a person who has a discrepancy between what they're telling me and what their score on their MoCA is showing, that would be another reason I would send them for a neuropsychologic exam, such as if a person is very highly educated and is telling me I'm really struggling with my memory, but they do fine on their MoCA, well then I would still send them for further evaluation.
It must be really hard for a patient when you finally give a diagnosis of dementia, and it must be really hard for their family too. What do you do next, Brett?
Well, you're right, Terry. It's a very difficult message to deliver, and certainly hard for families. And we could have a whole lecture on this topic, but let me just give a few tips to providers out there watching our broadcast. The first thing is it's important to involve other disciplines in taking care of this patient. We've got the medical care, but we also want to involve disciplines like social work, occupational therapy, speech, psychology. All these different disciplines offer services and programs that can help patients with dementia. So it's important that we also consider function. And when I'm talking about function, I'm really speaking about patient safety. So that would be things like driving, medication usage, firearms, even their finances, and then more generally just how they're managing at home. Can they be alone, or do they need to have supervision to make sure that they're safe? And we're going to be tracking this over time as the patient's cognition changes. And then finally, we want to think about the caregiver. They're a really important part of the treatment team here. They are kind of the front line of patient care for this individual. Certainly, it's a stressful experience sometimes, caregiving. And so fortunately in the VA, we have a lot of services available to help caregivers. There are many community services that we can suggest to those caregivers. And so we want to early on be thinking about the caregiver and helping them to connect with these different services.
Yeah, it's good that there are resources out there for the caregiver, because sometimes people forget about that aspect of it. We're just about out of time for our broadcast today, but before we go, I'd like our panel of doctors to share one final thought with us. Dustin, we'll start with you.
I think it's really important to consider the value of assessing cognitive change in older individuals. And the MoCA is a tool that we can use very easily to do that. It is reliable, it's relatively brief, it's got good validity, and it can be administered by a large number of people.
All right, Brett, your thoughts?
Well, to add on what Dustin just said, MoCA is a great test, but it's really a starting point in the process of evaluating for dementia. So we need to, in addition to doing that test, there are a whole host of other things that we want to be thinking about and measuring to make sure that we're coming up with the best and most accurate diagnosis possible.
And Natalie, what would you like our viewers to take away from all this?
I absolutely agree with the two main points that Dustin and Brett just made. And additionally, from the primary care perspective, then just remembering that identifying cognitive impairment early is just so important, because it really does impact the way that we care for our patients and can really help them prepare for the future and preventing upcoming problems.
Well, I've got to tell you, my own family and my ancestry, there's a history of dementia and Alzheimer's, so I found today's discussion extremely interesting, extremely informative, and I hope you did too. I want to thank our guests once again, Dustin Hammers, Brett Hicken, and Natalie Manley. With that, I'm Terry Wood. Thank you very much for watching today, and thank you for all you do for America's veterans.